This is Jimmy Pruitt, and you listen to another episode of the Pharm So Hard Podcast.
So I farm so hard, the employees want to find me, and then want to hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never want to see another B unless I'm Jay-Z.
What's good, fam? It's your host, Jimmy Pruitt, a.k.a. PharmD and ED, and I'm bringing you another episode of the Pharm So Hard Podcast. I'm super excited to be starting off this new year with a new episode and really hitting a old topic. It's going to be a really, really cool one. But before we jump into it, again, few announcements to get us on the road. Again, first question, Jimmy, where the heck have you been? Well, I've been a little busy. One of the key things I've been doing has been president and the executive director of the Society of Emergency Medicine Pharmacists. That has been a huge undertaking, but one of the most satisfying things we've done in a while. And it's really been a great work getting all the individuals on the team, getting the committee set up, working with everyone, really being able to hear what those in the EO community wants, and really kind of taking what we've built from the ground up, really from the Pharmacy Pearls to the podcast to the Empower RX conference to the society. Has really been about what the listeners, what the people, what the members, what they want, and figuring out a way for us to kind of be for us and by us in that aspect as well. So I've been spending a lot of time doing that. Another thing that's come up is that I am the new RPD of our PGY2 program in emergency medicine at Carolinas Medical Center, and that's been a huge undertaking as well. Shout out to my accreditors that'll be here in a couple weeks of this recording. So that's been exciting, but a lot of new activities, a lot of things going on. Never thought I'd be in some of these positions, but it's been really exciting and really humbling, to be honest. So that's been what I've been doing while we haven't been recording as many episodes, because I've been trying to focus on how to really leverage all of this and give you guys what you need as far as my attention and what I have to do as part of my term for this year. So really excited about that. Again, for you guys that are ready for this upcoming year of our Empower RX conference, we're going to be having that April 10th to 11th in Orlando, Florida. That's home for me. So super excited to have a homecoming. We have Ruben Santiago as our keynote speaker. We have a ton of really cool things. We have some in-person workshops. So we're really trying to take the conference and listen to what the attendees have said over the years of how to make it better. And really that means making it to where we can go get your hands dirty, do a few cool things. I have a huge surprise that everyone's going to hear about once we do it. So it's going to be really exciting for you guys who haven't signed up yet. Definitely do. Early bird special is going to be done January 15th. So you guys should definitely check in for that. But let's transition to this episode. We have a really, really big one today. And it's going to be really exciting because it's going to be an old topic. It's going to be something that we've been chatting about for quite a while, guys. And I think it's something that you guys are really going to enjoy because it's going to be the RSI trial, again, ketamine versus Etomidate in critically ill patients. It has really been challenging this 20-year idea. And before I even get started, again, these are some of my favorite drugs. And there are so many great things about them, but we have to get to what the data says. And let's look at what we've been going through over the last 20 years and really dive deep into it. And we all know the dogma. You're in the trauma bay and you get a patient comes in, their pressure is super soft, maybe like 80s over 40s. The resident looks at you and say, hey, Jimmy, they're unstable, so let's use ketamine. It's going to support their blood pressure. But on the flip side, we've also been taught that Etomidate is really going to be the boogeyman in a sense when it comes to what we're trying to do in patients that potentially have soft pressures or septic shock. It could be a death sentence for them. So the rule has kind of been ketamine for shock and Etomidate for stability. But this RSI trial dropped recently in New England Journal of Medicine, and it completely kind of shattered this paradigm for me, to be honest. And it really took all the different data and all the things we've been kind of teasing out and confounded this, confounded that, and just really kind of helped us understand. We're talking about 2,300 patients in a multi-center randomized controlled trial. The results, they suggest that we should use, the drug that's going to be the best for us at that time. However, that particular drug that I thought going into the study was not that drug. So today we're going to dive a little deeper into this, look into some of the background, and we're going to talk about the hemodynamic paradox when it comes to figuring out what you need to do on your next shift in your next hypotensive patient when they come in. After you get done listening to this, you're going to know exactly what to do. So the old dogma that we've been living by for quite a while has been this phenomenon of us basically saying that ketamine is going to be the safe drug because it's sympathomimetic, supports blood pressure, and is used in shocks. Etomidate was the risky one. Adrenal suppression, the fear of death and sepsis. We definitely should avoid this in all types of shock. And that was some of the background knowledge when it came to this. But the warning signs were there. There's some previous data, again, in the 2020 near registry, 7,000 ED intubations. And what they found was that ketamine was associated with a higher increase in hypotension, 18% versus 12%. But we dismissed this as confounding by indication. There's another trial that looked at this in 2022, and they used a slightly lower dose of 1.2, and those patients, again, needed more rescue vasopressors. Again, ketamine is probably, if you ask anyone who knows me, I'm ketamine. And the more I looked at this, and the more I saw it in my own patients, and after the first 100 intubations, after the second, after 1,000, after quite a bit of intubations, and having intubations every day for 90 years, it became more and more prevalent that I need to start looking at this data. So this study was meant to be like the definitive answers. A few other trials that looked at this, some OG studies that was done back in 2009 that started the trend. But again, those were the two big ones. And this RSI trial is supposed to have been the one that really took it all. So the study was, again, 2,300 critically ill patients and 14 EDs and ICUs. About half of them had sepsis or septic shock. Almost a quarter of them was already on pressors, and they randomized them 1-to-1 to ketamine or etomidate. And the cool part was that these were actually real patients. These were real sick ones. So no elective surgeries. Again, half of them were sick. 1 in 5 are on pressors. These are the patients that we're seeing in the ED and ICU, the sick ones, the ones that we can actually look at the data and say, I can extrapolate this to my patient. So what do they find? Let's just jump right into it. Does etomidate kill people? Is it really the worst drug in the world? And from this, just like almost anything else that looks at 28-day mortality in ED and ICU patients, they didn't find a big difference. Again, 20% in ketamine, 29% in etomidate. Again, p-value is 0.65. No difference. So the adrenal suppression fear, we can probably put that to bed with the primary outcome. The second question that I have coming into this one is, okay, well, if the adrenal suppression doesn't kill you, let's kind of dial it back here and see what can I find in the secondary outcomes when it comes to cardiovascular collapse. And this is what we found. We found this bombshell that cardiovascular collapse in 2 hours, we had more with ketamine than we did with etomidate. And that was going to be 22% with ketamine compared to 17% with etomidate. And it was a 5.1% absolute increase. Again, you harm 20 patients with ketamine. Again, that's going to be one extra collapse. Again, you can play around with the data and the words, but again, realistically, it starts to get challenging when you look at that. And what I wanted to do is dive a little deeper into this. Pull up the actual chart so we can start to lay our odds on a few outcomes, because I believe that's where it becomes really intriguing when we start looking at some of this. Now, when you look over, of course, we have our primary outcome here. We saw this initial component, and what we was able to see, again, is that same thing. But when we looked over, and the first thing I wanted to see was, this was a composite endpoint. Again, cardiovascular collapse in that first 2 hours. Doing induction 2 minutes after, what we was able to find was that the recipient of new or increased vasopressors was the driver. That was the statistically significant component of this, with 21% compared to 15.9. Systolic blood pressure less than 65 was not a huge thing at 6.4% compared to 5.5. And that made me pause for a second, and about the same thing when it came to cardiac arrest. So again, not more cardiac arrest, but something caused them to either start or increase a vasopressor. I'm going to be honest, guys. Again, in practice, when I'm dealing with ketamine, that's probably something I would do at baseline in some of these patients. So I think that for me, if I'm nervous and I have a patient that's sick, I'm going to go ahead and start them on a vasopressor. And if I do it correctly, and we're doing our whole resuscitate before intubate phenomenon, Then from there, I wouldn't necessarily have to increase it if I'm looking at it from drug to drug. And I had some people say, hey, well, Jimmy, well, obviously it wasn't that bad if those patients didn't get super hypotensive. And that number that they want to classify was looking at the secondary outcome of 65. But then we start looking around a little bit more. We did have a decrease in the systolic blood pressure less than 80, which I would argue is pretty important as well. But you have to do a little digging to find something else that I thought was really intriguing. I'm going to stroll up here because I highlighted it. When they looked at the decrease in systolic blood pressure of more than 30 millimeters of mercury during this time frame, 24% in the ketamine group compared to about 15% in the Etomidate group, and that's a 9.2% difference between the two that was statistically significant, had a huge drop. In my head, that says that people tanked in that group. Again, about 1 in 4 of them tanked. And that was something that really made me consider things. Because if you have a patient that drops more than 30 points in the systolic, that's a bit challenging, and that can be really dangerous for us. And I know some providers who will completely shy away from ever using propofol in some of these hypertensive status epilepticus patients, or in some of these other patients that, again, we may do it, but they would shy away from it solely due to some of the prior studies looking at a decrease in systolic blood pressure by 20%. This is right in the same realm, in a sense, which is wild to me to even say that there's a study, again, not the same exact patient population, but there's a study that looks at using propofol for induction and it drops blood pressure about 20%. This study, well done, well organized, drops blood pressure by 30 points and 24% of their patients. Wild. And there's no way to really go about that, guys. You have to ask yourself that, hey, is there something I have to look at in these patients, and I have to stop the same dogma over and over and over again when it comes to the use of ketamine in these sicker patients? So something to definitely be intrigued with. And then when we looked at these patients in septic shock, I was expecting to kind of see this thing kind of equal out a little bit, but that didn't happen. Again, these patients were even worse in the ketamine group in septic shock patients as well. Again, nearly 10% difference. So again, it dropped the blood pressure, guys. We can play around with this any way we want to, but it dropped the blood pressure. And it really brings me to this ketamine paradox. Like, how can it be a sympathomimetic and cause more hypotension? And ketamine, to me, in the way I think of it, and we can get really nerdy here with some of the animal studies and go back into it, but ketamine is doing really, to me, 2 different things at one time. You have this dual kind of nature of it, where you have this indirect sympathomimetic stimulation. Really, what I think of is I squeeze the adrenal gland. Again, I can make sure I can kick up some norepinephrine. So in my head, I'm basically giving a lot more of that. I'm basically giving like endogenous, norepinephrine. And remember, these blocking the reuptake of it. You can increase your catecholamine circulating around. Of course, that's going to block the blood pressure. It's going to raise the blood pressure. But then there's another component that, again, some people are arguing about, and some data's out there, and we can look at this, is that you also have this negative inotropy that can happen with all of ketamine's, 12 to 13 mechanism of actions. Again, there is some phenomenon that maybe it can have some calcium channel blockade. And the way that I think of this, if I'm going to talk to a resident, I'm going to talk to a nurse, I can say that maybe the way I think of it is, if I give a push dose of epinephrine of maybe 10 micrograms, but I'm also giving 0.5 of DILT. If I'm giving that big dose of the push dose epi, 9.9 times out of 10 is going to overcome that. And that's going to be in my patients that are not catecholamine depleted. And you're never really going to see the impact of that 0.5 milligrams of DILT. So that happens. But what happens when I wipe away that and I have a patient that doesn't have that amount of epinephrine in the system? I don't give a push dose, and I just give that 0.5 and they're already sick. In a subset of patients, they can become hypotensive. And that's the way I like to think of it. I want to make sure that all patients that are sick either have their own catecholamines. Again, these are people who are not shot, that lost a ton of blood on the scene, that I always say, is there epi on the floor? Or These are Mima, who's been in a nursing home that's been septic for 3 days, that come in super dry, super altered. These are the people who I'm like, hey, their catecholamines are, again, not where they need to be. These are the ones I'm really worried about. So the way I think of it, you can block that reuptake, norepinephrine can flood the system, the indirect wins in the case where you have catecholamines in the body. But then when you try to block that, there's nothing to reuptake. You have that indirect effect that really fails, and you only have that depression that remains behind. So if you think of it as a dried lemon analogy, you try to squeeze out a dried up lemon, ketamine squeezes hard, but nothing comes out. You just really crush the lemon. So you kind of get yourself in a bad position when it comes to that. And we've been talking about these drugs, and I'm going to have some people send some hate mail. I'm okay with that. And they're going to say, Jimmy, if this is the case, if ketamine's so bad, why did we miss the signal? And realistically, we've been seeing certain things, and we give ketamine to the sickest patients. Of course, they did worse. They're already crashing. But again, if we have a group of sick patients on both sides, and you say that Etomidate is the devil, and it can kill people that's super sick, if I look at a similar population of septic people, ketamine should do better. But that wasn't necessarily the case. These people tanked. Again, they tanked. Again, 24% of them dropped by 30 points. It tanks. Your pressure's soft after that. It changes the way you operate. And I talked to Dr. Michael Gibbs and a few of the others, and we want the most boring intubations possible when it comes to hemodynamics. For my physicians, they have a hard enough job. Again, getting a tube in, we try to make it seem like it's just this very easy thing because we do it every day, but it's a challenging thing to do, and life and death really depends on it. And I've been in some cases where things have went bad, and I've been in an hour intubation where there's been 6 different people attempt. And you want to make sure that if the airway self, let's just focus on the airway. We don't want a tank in blood pressure in addition to all the things going on. So I think the RSI trial really randomized the bias away, and that signal remained. It was probably the drug. And we just have to account for this in our thought process. When the pharmacist and the team and the nursing staff, when we're doing your 7 Ps and preparing, I'm preparing for what can make this patient tank. And I'm slowly but surely introducing the idea of, if we're going to do something like ketamine, let's prepare for the patient to tank. Let's prepare for all these components. Let's not think immediately that every patient's going to just spike up their blood pressure. The other question that came with this is that, did they use too big of a dose? The standard dosing of this can be 1 to 2. 1.5 is the traditional ring, and they got about 140 of ketamine. We're close to 0.3 mg per kg of Etomidate. And there are some people that want to use the lower end of the dose, and I just don't know. Again, if you're in shock, your volume distribution kind of contracts. The same dose can get a higher peak, and you have a relative overdose in the shock physiology, and it really hits the heart like a truck in a sense. What I don't want to do is sit up here and promote or pretend to promote this concept of low dose sedation and high dose paralytic. I'm not saying that. That's not something I'm promoting, but I think that when we look at our drugs, we have to really optimize for that, because I've seen people say, let's give them 25 of ketamine and 200 of rock. That's not what we're getting at here. There may exist a sweet spot of using just 1 mg per kg, or, kind of getting to that other side to where we can really start to get a better sense of not maybe going all the way to the 2 or going to 1.5. Maybe that 1 may be a better spot for us. But the counterpart of all of that as well is that Etomidate at standard dosing handled the physiology just fine. So is it really just a drug? And we know that Mattson and colleagues looked at this, again, found that 36.5% hypotension went full dose. And they looked at that greater than 1.25. Again, the dosing does matter, but standard dosing failed. Again, lower doses may be safer, but again, I will continuously repeat, we don't have shown data for that, and we can start getting into statistical gymnastics when it comes to the studies that looked at this. So for me, I'm to the point now where I want things to be boring. To me, for the most part, if I say Etomidate and whatever paralytic that you want, it's going to be it's going to be a stable going to be a very predictable thing. I can knock you out with 20. I can knock out almost any patient with 20 of etomidate. Again, we can argue about whether we want to use lean body, ideal body, whatever. I can knock you out. And everyone knows you can knock a patient out with a decent dose of etomidate, because when you use it for your patients that you're doing procedural sedation on to shock them and to cardiovert them, the 5 milligrams or the 0.15 milligrams knock those patients out very nicely for the period of time they need to be. So even with this whole adrenal suppression component, patient live just as long and crash less. So for me, I'm much more on the look at the patient, look at the scenario, choose one of the options. And in some of the shock patients, I think that maybe etomidate we should look at a little bit more. So let's wrap this up, guys. I don't want to chat too long. Biggest things from this: stop fearing etomidate. Etomidate has now proven in sepsis or any undifferentiated shock, it's probably going to be a superior agent. I say that as a person who loves ketamine, but it's probably going to be the superior agent. When you look at the other components, looking at this, is that you have to respect ketamine. And I think ketamine is not a free lunch. It's still useful for status. It's still useful for asthma, delayed sequence. You can't treat it as safe in a sense. And I think that if you go into it thinking that and setting up, maybe you have a Norpy drip started a little earlier. I personally believe that in a patient that blood pressure is less than 130 over 80, we should start everyone on a very small dose of norepinephrine and just have it there, and always have a very boring intubation and have just some catecholamines flowing as part of us pre-oxygenating and getting these sicker patients set up. So giving the fluids, get what they need. But my docs now are asking, hey, do you have a push dose? And I say, well, I can have a push dose available, or I can start a little bit of Norpy in the background. So however you want to do that, whether you start an infusion or you give some push dose of your norepi or your phenylephrine or whatever it's going to be. Again, I think that's something to consider. But again, don't treat ketamine as just completely safe. Again, modify the dose. Again, the dose, we may be cutting it, man. This is, when I made this, it made me super, super nervous. Again, I would probably aim closer to that 1 mg per kg, because again, I've realized that this may be used in that patient population that I'm not intending for it to be used in, or maybe taken out of context in a sense. But again, maybe cut that dose. Again, if we're given a super big dose, we may be cutting back a little bit, and that perfect dose for these patients alongside some push dose may be the perfect scenario. And just be ready. Again, I've mentioned it time and time again. Figure out what you're going to need, expect the dip, don't be surprised, and have everything set. And as a pharmacist, this is part of my preparation. It's always having a drug ready, always having Norpy on the pump, always being certain of what the plan is about the blood pressure, and it's just taking this off my team's hands. But I think we have to start asking ourselves when to avoid ketamine. Again, I love the drug. Maybe in severe acidosis. Again, these patients that have DK, the myocardial depression potentially could be bad. Again, a little softer on that. Some heart failure, the older patients, again. But really, to me, where I feel the biggest challenge is going to be this catecholamine depletion. Either prolonged shock, already maxed out on something, or these are trauma patients that have a ton of blood loss and you're doing all of the MTP and et cetera. Just realize that these patients may tank. So, is this a paradigm shift, guys? Is this a paradigm shift to unlearn the idea that ketamine is a suppressor at all times? And in our sickest patients, ketamine may be a depressant, and we have to just be focused on that. But let's just not get too carried away here. Again, this is a single dose study, one intubation. They looked at just over a period of time. There was no guidance on the optimal dosing. Sepsis was about 50% of the cohort. Again, the medium dose was at 1.6. We don't know if a lower dose will be safer. So we have to kind of keep all those things in mind. And what this doesn't mean, and I just want to clearly say this, it doesn't mean to not ever use ketamine again. It doesn't mean that ketamine is bad in all scenarios. And it doesn't mean that etomidate is perfect for everyone. The context really matters, and the choosing wisely based on physiology and respecting the drug's limitations, respecting both of their limitations, and just thinking about this. And I know a lot of time we don't have time to think about what drug we're just going to just use the same thing, the same dose in every patient. And I would say make sure you have an ED pharmacist, or make sure you have an ICU pharmacist that can help offload some of that if we can, to really get us going. So for me, the way I look at this, and I say, hey, if I'm going to be using this and I got a patient that's super sick, that's septic or undifferentiated, I want to use Etomidate. RD pressors, prolonged hypotension, shock index greater than 1, I want to use Etomidate. Anything else, again, asthma, bronchospasm, DSI, status, any of those other cases, I really want to use ketamine for those. And if I have to use a lower dose, I will. But more importantly, I think the better recommendation for me that I feel more comfortable with, and I have a lot of antidote on, is making sure you have pressors ready. All right, guys, lots of information, lots of thoughts, lots of everything, but really appreciate you guys listening for this episode. And just really overall, we've been doing Pharm So Hard going on 6 years now, and we're over 120 episodes, and we've really, as a community, and I don't think of the podcast as myself, but I think of it as a community, what we've been able to do over the years is really expand our thought, our influence from what it was to just doing a few episodes here to me being too busy to do episodes every single few weeks because of all the other things that we've been able to grow our society, grow our influence all over the world. So really excited about that. Again, if you guys want to learn more about the conference, again, it's going to be in Orlando, Florida this year, April 10th and 11th. We have a virtual day. That's that following Monday. That's going to be at empowerrx.conference.com. Again, we're going to be breaking down studies like this. Ton of a community. The coolest thing ever is that, again, it's such a relaxed environment. We're going to have a huge party. It's going to be exciting to kind of be there and network and do great things. This year, we're making sure we're putting on for the residents that the residents abstract we actually published in the Journal of Acute Care Pharmacotherapy. Let me pull that forward for you guys so you can see. You get to see this in live in effect again. And we're super excited to have the Journal of Acute Care Pharmacotherapy as our own of the SCMP's official journal. So super excited about that. The residents will be posted in here. We've most recently had our first volume come out December 1st. It was really, really cool to do all that. Shout out to Brian Gilbert, our editor-in-chief. Shout out to Christopher Edwards, our deputy editor, for all of the hard work that they did to get that journal up and going. All of our advisory boards, again, Judah Jacoby, Brian Erstad, and Frank Polishek, again, Carlton Maxwell, all the individuals who's really been helpful in guiding us. Because again, you don't just start a journal. You don't just start a society. You have people help you move forward. And I think I've been super fortunate to meet some of the brightest minds, but more importantly, some of the people who really want to help out, and super excited for all the things that we're going to be doing. And it's been truly a blessing, guys. So starting off 2026 with a bang, and I'm just overjoyed with everything that we're doing in the society, the conference, and it's going to be a really, really cool event for you guys to come to in Orlando. But guys, as I end every single episode, you don't have to be a pharmacist, you don't work in the ED, but everything you do, make sure you farm so hard.
Ozzy scratches his head. Whatever she's looking for, it isn't in there.
Perfect.